welcome. This is our webinar on radiation therapies. So we're thrilled that you're joining us.
Funny.
And just as a housekeeping note, if everybody can please go ahead and make sure they mute themselves when they join, that would be helpful. And also to turn off your cameras. We do record these programs and we want to make sure that we are not violating anyone's privacy because we will post this after the program. So please turn off your camera and mute yourself. So tonight we want to give a heartfelt thank you to our corporate partners and our individual donors. Thanks for making these wonderful programs possible. Tonight we have with us Dr. Christopher Kelsey from Duke University Medical Center. Welcome, Dr. Kelsey. Thank you so much for being here with us tonight.
Thank you.
So I'm going to go ahead and stop sharing my screen so that Dr. Kelsey can take over and share with us about radiation therapy.
All right. Does that look right?
It does. And just so people know, if you have questions during the program, please go ahead and enter them into the chat at the bottom of your screen. You should see a little toolbar. It says chat. You can type your question in and we will get to the questions as time allows after the presentation. So
just FYI, you're in presentation mode right now. You're in a presenter mode, rather. Presenter mode, sorry.
So let's see. I need to be in
that little icon at the bottom right with the big screen.
It says slideshow.
Yep.
I think it's because I have two screens on my.
Try when you enter into that screen, Dr. Kelsey. Try hitting. So try it again, what you just did.
Click on
at the bottom right. Oops. Did you freeze? There we go. No. So at the bottom screen, there you go. Click that icon. There you go.
Did that work?
It did.
All right. The issue is my laptop is hooked up to a couple of monitors and it throws things off for the screen. So for some reason, this is not connecting. Let's see here. Okay.
Is it all set?
I think so. Can you see my screen now? Okay.
Yes.
All righty. Well, thank you for this opportunity to spend some time talking about radiation therapy for mycosis fungoides. As was mentioned earlier, my name is Chris Kelsey. I'm a radiation oncologist. I've been at Duke for about 17 years or so. I'm also the late doctor in our department. And so there's a very slim chance I might have to freeze this presentation and answer a page if there's some emergency. So I just let the audience know that just in case. Okay, so in terms of skin lymphomas can either be T-cell malignancies or they can be B-cell malignancies. Of course, mycosis fungoides is a T-cell lymphoma. It's a cutaneous T-cell lymphoma. But I think it's important to see the big picture here is there's literally about a dozen different types of skin lymphoma. Most of them are T-cell, but occasionally patients will have B-cell non-Hodgkin lymphomas that arise in the skin. Mycosis fungoides is the heavy hitter. So 70% of all skin lymphomas are mycosis fungoides. So this is by far the most common skin lymphoma that we deal with in clinical practice. Mycosis fungoides is a disease of older adults. The median age is almost 60, and it's relatively rare. There's approximately 5 cases each year per million population. So in a state like North Carolina, where there are 10 million residents, there's about 50 new cases of this disease each year in this state. And there's a long duration from onset of mycosis fungoides symptoms to diagnosis. On average, about 4 years, patients are diagnosed with eczema or psoriasis or other skin disorders that can mimic mycosis fungoides, often for quite some time before the diagnosis is eventually secured. This disease is more common in males. It's more common in people, African Americans. And it generally evolves from patches to plaques to tumor stage disease. So in this slide here, I have some pictures, and panel A is a typical patch, which is a not very well circumscribed, kind of flat erythematous lesion without really discrete borders. And then in panel B, we have a typical plaque that's more raised, more circumscribed. You can kind of see where the edges of the lesion are much more clearly than a typical patch. And then in panel C is when the disease starts to grow more vertically, you get the development of overt tumors. In panel D, we have a patient who has Sezary syndrome, where they have erythroderma, where the skin is just diffusely infiltrated with lymphoma. And there's not discrete patches, plaques, or tumors, but just this deep redness to the skin. I won't talk much more about Sezary syndrome in this talk. So in terms of the management of mycosis fungoides, there are a number of different treatments. And they can roughly be divided into those that are directed to the skin and those that are more systemic in nature. So skin-directed treatments would include such things as topical steroids, topical chemotherapy like nitrogen mustard that's often administered directly to the skin, light therapy, which includes both puva as well as narrowband UVB light therapy. And radiation therapy is also a skin-directed treatment. And then there are systemic treatments. These are modalities that are either given by injection or a pill that somebody takes, or an infusion like chemotherapy. And so those are often incorporated in the management of mycosis fungoides as well. Now I'm going to back up because I think several of my slides didn't get, okay. So today we're going to talk about radiation. So radiation is sort of this enigma that people wonder, what in the world is radiation? So I thought it might be, at the very least, entertaining to learn more about what exactly is radiation therapy. So radiation is pretty simple. It's these electromagnetic waves that have both an electric and a magnetic component that are perpendicular to one another, and they propagate like a wave through space. And there are many different types of radiation, each with different characteristics. So radio waves is electromagnetic radiation. So is microwaves, infrared, the visible light spectrum, UV light, X-rays, and gamma rays. This is a spectrum of different types of radiation. And as you go from left to right, the energy level of that electromagnetic wave goes up as the wavelength decreases and the frequency increases. So you can see how the waves are much more compressed in types of radiation that have high energy, like X-rays or gamma rays. Now, there's basically two types of radiation. There's non-ionizing radiation, and then there's ionizing radiation. So non-ionizing radiation are things that we experience every day. So radio waves, we use the microwave, the visible light, the spectrum. All of this is non-ionizing, and I'll talk about what ionizing means in a minute. And then we have radiation that's ionizing. This is the radiation that can affect biological processes. This is the radiation that we need to be more concerned about in our daily lives. So it includes UV light, like you get at a tanning booth, X-rays, for example, when you get a chest X-ray, when a patient is thought to have pneumonia or some other disease in the chest. And then there's gamma rays. So these are the three types of ionizing radiation that can actually affect biology. So what exactly is ionizing radiation? So any radiation that has sufficient energy to cause an orbiting electron in an atom to be ejected, that is what's called ionizing radiation, because instead of having a neutral atom with an equal number of electrons and protons, when that electron in a outermost orbit gets ejected because of the photon or the radiation wave that propagates through space and hits it, that will cause the atom to be ionized. It'll have charge, and that will affect biological processes. Now, what most people don't realize is every single day of your life, you are exposed to ionizing radiation. It is ubiquitous. It is everywhere. We're all exposed to radiation. Very small amounts, but it's everywhere. So for example, each day we inhale radon. Very, very small amounts, unless you live in some parts of the country where radon is more ubiquitous. But radon is a byproduct of normal radioactive decay of elements in the earth. And we inhale this radiation. In addition, the sun and the stars release ionizing radiation that propagates through space. Much of that gets shielded by our atmosphere, but some of it penetrates. There's radioactive atoms in the soil, and that can affect produce. And just rocks in the earth will release radiation up through the ground. So each year, we're exposed to about 3 millisieverts of radiation every single year. Now, these are very small amounts, and they don't have a high likelihood of causing any harm, but it's just important to realize that we're all exposed to radiation every single day. And actually, where a lot of our natural, well, not so much natural, but background radiation comes from is medicine. So when you come to the hospital, you get a CT scan, you get fluoroscopy, you get a chest x-ray, you get a PET scan. All of these things use radiation and contribute to our average daily dose of radiation that is administered to us. So on average, from background radiation, we get about 3 millisieverts, which is just a measurement. And on average, the average American gets 3 more from x-rays and CT scans and the like. So on average, we're exposed to 6 millisieverts a year. So this is how radiation kills cancer. The photon, or the electromagnetic ray that's generated by machines, enters into the body and it interacts with atoms, mostly water. And these electrons get ejected out from the atoms, interacts with water, which creates these hydroxyl radicals, which damages DNA. It's that simple. The radiation will cause water to be ionized and have energy, and it damages the DNA. And cancer cells are not really good at fixing their DNA from this type of damage, while normal cells are much more able to fix this. So there's a difference in the biological effect of the radiation, where the cancer cells are more likely to die because their DNA is damaged. The normal cells are far more likely to be healed because they have the proper machinery in place to fix those problems. So how do we generate radiation? Well, we have these machines called linear accelerators. These are very large machines that are in these rooms called vaults that are lined with thick lead walls to protect people that are not inside the machine or inside the room. And you lie on the table, and the machine will aim radiation therapy at the tumor. And that radiation therapy are called x-rays. And these x-rays are high energy, and they treat the tumor that we need to treat. Now, the way that radiation therapy works from beginning to end is if your dermatologist or medical oncologist feels that radiation therapy may be an appropriate treatment for you, then first you're set up for a consultation to see the radiation oncologist, for them to evaluate the skin and evaluate the treatments that you've had in the past. That typically takes about an hour or so. And then we have what's called a simulation. A simulation can either be simple or complex. And that's where we design radiation fields that will treat the tumor. And then we have to do, after the patient leaves, we have to do all these calculations and modeling and quality assurance to ensure that the tumor that we treat gets the radiation dose that's been prescribed and that it's administered safely. And so all of this is typically done with computers. And then when you come back to start the radiation therapy, you receive your treatments. And most treatments take around 15 minutes or so. So it's usually a pretty brief episode. The treatment itself may only take 2 or 3 minutes. The setup typically takes the longest amount of time. Now, there are 2 main types of radiation that we use in cutaneous T-cell lymphomas, mycosis fungoides, of course, being the most common one. Electrons and photons. And I'll talk a little bit about the difference between those 2 types of radiation. And then there's 2 general techniques, either localized radiation, where we treat individual plaques or tumors. And then there's what we call total skin electron beam therapy. That's where we treat the entire skin with radiation therapy. First, we'll talk about electrons. Electrons are superficial radiation. They treat the skin, but they don't penetrate very deep. So in this schematic, we see a representative electron beam where these individual lines are kind of like topography lines on a map, where on a topography map, the lines indicate different elevations. And so if lines are really close together, it might be a mountain where it's very steep. Well, that's what we have here. The dose falls off very quickly from 100% of the dose down to 10% in a matter of about a centimeter. So in this particular beam, by the time you get down to 3 centimeters, which is about a couple inches, the radiation is gone. So electrons just treat the superficial skin, and we use electrons most frequently when we treat mycosis fungoides. You might have some tumors that are thicker than other tumors or other plaques. And when we treat people with electrons, we can choose the energy level that will match the tumor that we need to treat. So this orange is a 6 MeV beam. Whoop, went too fast. 6 MeV beam, where basically the beam only penetrates about 2 centimeters, while a 9 MeV beam, which is the blue color, will go closer to 3 centimeters. So we can choose what energy we need based on the clinical circumstances. So here's a patient who had a skin lymphoma that was treated with radiation therapy. You can see this plaque with a raised lesion, a raised component near the bottom part. And when we treat with electrons, it's actually pretty simple. We draw a field around the plaque that includes not only what we can see, but also a centimeter or so on both sides, because the electron beam has what's called a penumbra. It has a blurred edge. And so in order that the entire tumor gets the full dose, you have to put a bit of a margin on it. Plus, we want to make sure that any microscopic disease that's underneath the skin that you may not be able to see or feel gets adequately treated. So we design it basically just by using a pen and a ruler around the tumor, and then we create what's called an electron cutout. That's in panel B at the bottom. And that's a cutout that corresponds with the treatment field, and that goes inside the head of the machine and collimates or focuses the radiation beam to treat what we want to treat. So here's a patient that I treated who had a cutaneous T-cell lymphoma. This isn't mycosis fungoides, it's actually primary cutaneous anaplastic large cell lymphoma. And the lesion was mostly in one central piece, but you can see that there are these satellite lesions around it. So we were kind of generous to make sure we got not only the primary tumor, but any satellite lesions. And this was such a large area that we actually had to divide the electron field into two separate areas. And the patient lied on their stomach, and the radiation beam was focused to treat that area. And after radiation therapy, the lymphoma went into a complete response. You can see some tanning of the skin, which we see with radiation therapy. And over time, this tanning will fade back down to the normal pigment in most people. Here's another patient who had this was a primary cutaneous B-cell lymphoma. Again, a very simple electron field that just treated the patient's left shoulder. And after 2 months after treatment, it had gone completely away. So that's electrons. By far, we use electrons more than anything else when we treat mycosis fungoides because it's involving the skin. And usually the electrons allow us to treat the lesion and avoid treating anything deeper in, like the lungs or the heart or other organs. Those are usually completely spared from the radiation because the electron beam just doesn't penetrate that deep. Every once in a while, though, you'll have a patient that has a much deeper tumor. This is a patient with mycosis fungoides where there was a visible tumor above the skin, but most of it was deep, almost like an iceberg. It went way down clear to the abdominal wall. Now, electrons are not optimal for such deep tumors. So this is where we use photons. Photons are a more deeply penetrating type of radiation that we use all the time to treat different cancers, lung cancer, rectal cancer, breast cancer. Most cancers are not sitting right on top of the skin surface where we can use electrons. So in this patient, we had to use photons. And the way that photons work is we will use a number of radiation beams. It can be 1 beam, 3 beams, 9 beams, whatever is necessary to create a radiation dose distribution that will treat the entire lesion. So this patient was treated with a photon beam from the left, a photon beam from the right, and then a photon beam from the front. And those 3 radiation beams created a dose distribution that completely encompassed the tumor, but minimized incidental radiation dose to the intestines and other structures deep down. So you can see how the green completely encircles the tumor. That's the full dose. And then the other lines that you can see are much lower doses of radiation. So these are photons. Again, we don't use this all that often with mycosis fungoides, but sometimes we need to. Now, mycosis fungoides, as everybody knows, is this wide spectrum of disease. Some patients will just have a few patches or plaques. Some people will have a few tumors, and some people will have widespread disease all over the skin. And so we take what the stage of the disease is to customize the optimal treatment. And as I mentioned before, we can use either localized radiation, where we just treat individual areas. We can use what's called total skin electron beam therapy, where we treat the entire skin. And I won't talk more about this, but we also use radiation therapy as a conditioning regimen as part of an allogeneic stem cell transplant, where patients may either get some local radiation or total skin or even total body irradiation to prepare them for transplant. So I won't talk more about that because that's just far less often utilized. So some patients will present with unilesional mycosis fungoides. I mean, they have one patch or one plaque, and that's it. It's rare, but it does happen. So this is a patient who had one patch on her left breast, and this was the only site of disease in her entire skin. The biopsy showed mycosis fungoides. She had CT scans, which showed no evidence of involved lymph nodes. And in patients who have unilesional stage 1A mycosis fungoides, the recommended treatment is radiation therapy alone. Because with radiation therapy, most patients will go into remission, and the vast majority of people will remain in remission. And typically we treat with 3 weeks of radiation therapy. So 1 treatment a day, 5 days a week for 3 weeks. That's what this patient received. And as you can see, 3 months post-radiation, the plaque was essentially gone and there was just some faint pigmentation changes that remained. So what's the data for this? This is a study from Yale, actually kind of an old study published in 1998. They looked at 900 patients that were treated at Yale over a 42-year time period. And of those patients, only 34 had what they called minimal stage 1A disease. This is, again, where there's just 1 lesion or a couple lesions in close proximity. So this is a very rare presentation of mycosis fungoides. But of those patients who had minimal stage 1A disease, so they had 13, I think I misspoke. There were 21 patients with what they called minimal 1A disease, and there were 13 of those 21 who had just 1 spot. So 13 patients had 1 spot, 8 additional patients had 2 to 3 lesions that were clustered. And after radiation therapy alone, the complete response rate was 97%. And that's typically what we see with mycosis fungoides. After courses of radiation, lesions almost always go away. 3 patients had a local failure. So the disease came back right where we did the radiation therapy. And that was with doses of 8, 20, and 20 gray. And again, like I talked about just a second ago, typically we recommend higher doses in this presentation. So a dose of more like 30 gray, which is 3 weeks of radiation. Of those patients who just had 1 lesion and received a dose of at least 20 gray, 91% were disease-free after 10 years. So I think this is a circumstance where patients are ostensibly cured of their mycosis fungoides. Again, it's very rare. This is another series from Milan of 15 patients. Again, after low doses of radiation, most people go into a complete remission. The local control was very high, 94% of patients. The disease did not come back where we did the radiation. After 10 years, half of the patients were still disease-free. So if you have a patient who has localized unilesional mycosis fungoides, just 1 spot, excuse me, we generally recommend radiation, one treatment a day, 5 days a week for 3 weeks, and that leads to very good outcomes. Now, the vast majority of patients with mycosis fungoides don't just have 1 spot. They have more than 1 spot, and often getting other treatments. Now, if a patient is undergoing interferon, for example, or targretin or light therapy, doesn't matter what it is, but they have a few troublesome plaques or tumors. For example, a plaque that's painful or really itchy or not responding to other treatments, or they have a tumor that's not doing very well with whatever therapy they're on, oftentimes patients are referred for radiation to treat those troublesome areas. So here's another patient that I treated some years ago. This individual was heavily pretreated. He's been through a lot of therapies. And at the time, he just had a couple of small bleeding plaques on his right arm. And so he was referred for radiation. You can see that small little radiation field that I put around the tumor. Now, how do we treat these patients? Now, this is a circumstance where the radiation is not a curative treatment. It's a palliative treatment. We're trying to palliate or treat individual lesions, knowing that they're going to need additional treatment. They're going to need to continue their interferon or their targretin or their light therapy or chemotherapy, whatever the case may be. And so we're not trying to maximize the radiation and rely wholly upon that. We're just trying to give just enough radiation therapy to make the lesion go away and hopefully not come back for a long time. Now, in other types of lymphoma, we often give a very low dose of radiation, 2 treatments, so 4 gray. And in other low-grade lymphomas, about 60 to 70% of patients, the lesion will go completely away. We see that with marginal zone lymphomas of the skin, follicle center cell lymphomas, and it's been looked at with mycosis fungoides, but did not prove to be that effective. The complete response rate wasn't very high. It was only 30%, and most patients had the disease come back within a year or two. However, if you just increase the radiation dose a little bit, from 4 gray to 8 gray, so still just 2 treatments, but a higher dose, in this particular study, the CR rate bumped up to 92%, and 80% of patients didn't have to get retreated to that area over the time period of follow-up. So in general, when we treat individual lesions, we like to give at least a dose of 8 gray. In this particular study, they gave 2 doses on back-to-back days. But another study from Northwestern University, they just gave 1 treatment. So they gave all 8 gray, or 7 gray in this particular study, 7 to 8 gray in a single treatment. And the complete response rate was still like 95%. And so in a lot of my patients, we will treat with just 1 dose of radiation, knowing that that's going to do a good job in the vast majority of people. However, we also know that if you give a higher dose of radiation, you're going to keep that plaque or that tumor in a good response for a longer time period. So this is an old study from Washington University, 1983. But it basically shows that with the higher doses of radiation, more like 2 weeks of radiation or 3 weeks of radiation, the tumor or the plaque will stay in remission longer. And so it kind of depends on the circumstances. It depends on how long the patient's been managing their mycosis fungoides, what other treatments they're getting, are they effective, how many lesions are not responding. So sometimes I'll just give 1 or 2 treatments, but sometimes I'll give more like 8 or 10 treatments depending upon the circumstances. So going back to this particular patient, they had these 2 small, shallow ulcerated plaques on their arm. We treated with 2 doses of radiation, and within a few weeks, they had gone completely away. All right. Now, and I would say that this is the more common scenario where I treat patients. Most of the people I treat don't just have 1 spot. I may treat 1 person a year who has unilesional mycosis fungoides, where we're treating with a course of radiation, hoping for cure. The vast majority of patients I treat are receiving lots of other treatments. They've had mycosis for a while, and we're treating individual spots to keep those in check, knowing that they're going to continue other treatments. But there are a number of patients who have widespread disease that's not responding to other treatments, especially patients with thick plaques or tumors, where their best treatment is total skin electron beam therapy. So here's another case presentation. This is a 62-year-old female who had skin nodules for about a year. Typical story, initially thought to be eczema, but they increased in size, and ultimately a biopsy confirmed mycosis fungoides. And this poor lady, when I saw her in the hospital, because she was admitted because of pain control, had numerous large ulcerated bleeding tumors throughout her body. And you can see this picture showing raised nodules that were just confluent on her face and forehead. And she had large ulcerated tumors all throughout her body. You can see the date here, October 2012. And because she had such widespread disease, total skin electron beam therapy was recommended. Now, the classic way we treat mycosis fungoides with total skin electron beam therapy is standing up. So patients need to stand. This can be really hard to stand for about 45 minutes to an hour. And in order to treat all the different parts of the skin, patients need to assume these different poses. that will cause all of the different skin surfaces to be treated effectively with the radiation therapy. And here's the patient that I wanted to show you before, and she did a great job standing for all of her radiation treatments with these different poses. It can be very challenging. Now, I'm going back to this picture. You can see that the patient is standing on this slightly elevated platform. She has shields, like these lead contact lenses to protect her eyes, so she can't see. She's got a lead shield in the mouth to protect the gums and the tongue, because often we don't want radiation to slip through the lips. So this can be really hard treatment, and sometimes patients can be older or not as strong as they used to be. And we had a couple of patients almost fall, which was very frightening. And we had lots of other patients who needed this treatment, but they just couldn't stand. So several years ago at Duke, we commissioned a lying down recumbent total skin electron beam therapy treatment. We designed a platform that people lie on. It took a couple of weeks with our physicist commissioning how the radiation would be given. This was not an easy endeavor, but we completed it. And now I would say half of our patients or more we treat lying down. It works really well. It's probably not quite as good as standing up in terms of the radiation homogeneity, that is making sure all the different parts of the skin gets exactly what you want, but it's much safer, and we haven't had anybody fall obviously with this recumbent technique. We eliminate that risk. So this patient got treated over a period of 6 weeks, where you get a small dose of radiation every day, 4 days a week for 6 weeks. You can see the dates: October 29th, 2012, the day she started, December 11th, 2012, the day she finished. And you can see how rapidly the radiation improved her skin lymphoma. And she basically went into a skin remission and was started on additional treatments to maintain that remission. So radiation will cause almost all patients to have either a very, very, very good partial response or a complete response. So total skin electron beam radiation is the optimal treatment for patients with widespread disease, especially if there's thick plaques or tumors, because a lot of treatments just don't penetrate deep enough to treat thick plaques or tumors, or if patients have had a poor response to other skin-directed therapies, and a total skin electron beam approach seems best. So what are the side effects when we do total skin irradiation? Oftentimes the skin will get a little irritated, and it can feel dry. Patients don't sweat as much after the radiation therapy for a period of 6 months or so, and so applying moisturizing lotion is really important. Sometimes little blisters can develop on the feet, and the hands, and sometimes the legs. Again, the skin is just very fragile, and little bits of trauma can cause blisters to develop. When we have to treat the scalp, there will be hair loss. It should grow back, but temporary, partial, or complete hair loss is possible. And then sometimes patients can develop ocular complications. Again, we have to put these lead contact lenses in the eyes. And sometimes I've had some patients develop irritation of the eyes or eye infections if there's introduced bacterial infection, for example. Some late complications, sometimes the fingernails and the toenails, which are part of the skin, can become dystrophic or get thickened and not have the same appearance as before. Sometimes hair loss can be more patchy after the radiation therapy. And there's sort of a theoretical risk of getting second skin cancers, because the radiation is kind of like getting a whole bunch of sun exposure. That's a little bit of a theoretical risk. I have not seen any of my patients get skin cancers after total skin electron beam therapy, but it certainly is possible. So again, just to summarize, we use radiation in lots of different scenarios, from essentially an attempted cure for patients who have minimal stage 1A, just a unilesional mycoses, local palliation for troublesome sites, and then total skin electron beam therapy if the disease is more widespread. Radiation is very effective. The vast majority of tumors and plaques will go away with a short course of treatment. The type of radiation, the number of treatments is based on the presentation. As I mentioned before, sometimes it's just one treatment if we're just treating one small lesion. And if we have to treat total skin electron beam therapy, it can be up to 24 treatments. For most people, radiation is really well tolerated. When we just treat individual lesions on the skin, side effects are usually minimal. Sometimes if a lesion is already kind of fragile and might be bleeding or oozing a little bit, sometimes that can get temporarily worse. But most people are not going to have many side effects from just treating superficial areas of the skin. But with total skin electron beam therapy, there are more side effects, as I mentioned. And I think that's the end of my presentation. So
wonderful. Thank you so much
for your attention. I'm happy to answer any questions that may have arisen.
Thank you so much. I feel like we're all much more knowledgeable now. Let's see. So we have a lot of questions. So just so everybody knows, we'll be able to take questions until the top of the hour. So the first one is, how common are cataracts following radiation to the eyebrow/bridge of the nose area? And then she added, this happened to me. I'm wondering if this because I now have CTCL in the other eyebrow.
Oh, that's a good question. So the lens of the eye is very sensitive to radiation therapy. And even really small doses can lead to accelerated cataract formation. Of course, as we age, everybody gets cataracts. It's part of aging, but the radiation can accelerate that. If you're treating, like, for example, the eyebrow or above the eye, and a shield, like a lead shield, is put inside the eye, then the dose should be very low and it shouldn't increase the risk of cataracts. Now, sometimes you can't put a shield in. Like, I've had some patients who had such extensive disease around the eyelid that we just couldn't separate the eye sufficiently to put in that lead contact lenses. And so we would have to treat the eye without the shield. And that certainly increases cataract formation. Now, cataracts are easy to fix. You take them out, the ophthalmologist puts in an artificial lens. And so in some patients, we're obliged to say, you know what, you might get a cataract from this, but we can fix it. We really just need to treat this tumor on your eye before it causes other problems.
Okay, great. Thank you. I had radiation to a tumor on the scalp, which was successful. The oncologist said there was a limit to how much radiation a person could get. Could you please explain why this is? Thanks.
That's a good question. So the good news is the skin can tolerate a lot of radiation if it's given over a long time period. So for example, some patients with breast cancer will get 6 weeks of radiation to the breast. And then years later, the cancer may come back, and we can, in most cases, give an additional 4 weeks of radiation pretty safely. So that's just to give you an idea of the numbers. That can be about 100 gray in terms of just the number. Most of my patients that we treat for mycoses are treated to 8 to 10 gray or so. And so that allows us to some flexibility to treat areas more than once if necessary. When we treat with total skin electron beam therapy, we either give a low dose or a high dose, but even the high dose is only 36 gray. So there is a limit to how much the skin can tolerate, but most patients with mycosis fungoides are getting such low doses that we can repeat it several times over a period of years.
Okay, great. I have Sezary syndrome and had TSEBT, sorry, I don't know the acronym, radiation about a month ago. How long does it take for hair growth to return? And then they added, what percentage does hair growth not return?
That's a good, well, it all depends on the dose of radiation. If people receive a standard course of total skin electron beam therapy, which is one treatment a day, 4 days a week for 6 to 8 weeks, depending on how the center, because everybody treats a little bit differently, like Duke treats a little bit different than Yale. But if you get 6 to 8 weeks of radiation, it may take 2 or 3 months for the hair really start to come back, but almost everybody should have reasonable hair regrowth after that. It's typically once you get above 40, 44 gray, which is above what we typically treat, where permanent hair loss is more likely.
Okay. What is the duration of response of localized radiation therapy? And then, so that's the first part. It's a two-part question. And then up to how many lesions and anatomical lesions radiation therapy can treat?
Right. So in terms of the number of sites that we can treat, if you think about it, it takes about 10 or 15 minutes to treat an individual area if it's a relatively simple electron field. I've had patients where I've treated 7 or 8 at a time. So it might take, an hour and a half to 2 hours for each of the treatments. But we do that if that's what's the best course of treatment for the patient. So in general, if patients need, let's just say 30 sites treated, that's typically when we're saying you kind of need total skin electron beam therapy, because it's just not practical to treat 30 individual lesions. How many lesions you treat kind of depends on the circumstances, but for me, I think I've treated at most 7 or 8 at a time. And then how long will it last? Well, it kind of depends a little bit on the dose of radiation. Depends whether it was a tumor or a plaque, because tumors tend to come back a little bit quicker than plaques. But after a typical radiation course, the lesions can remain controlled for 1, 2, 3 years. Now, that's not everybody. That's like an average. Some people will treat and it never comes back. Some people will give a low dose of radiation, like 2 treatments, and 6 months later it comes back. Well, if that happens, then I'll tell the patient, okay, we gave 2 treatments, we gave a low dose, it lasted for 6 months, that's really not satisfactory. What if this time we give 5 treatments, give a higher dose, because we know higher doses will lead to longer durations of response. And so everyone's a little different, and sometimes you just have, usually I'll start low and then give a higher dose if I need to.
Okay. I have plaques and patches all over from shoulders down to feet. I'm being treated by UV light therapy since September 2020 at 3 times weekly. Finally got to 1650J as of today. I'm told that I should expect months and months before going to maintenance schedule. At what point should I ask for an alternative such as this therapy? I still have some plaques that aren't responding as well.
So in patients who are being treated with light therapy, which sounds like this patient is receiving, sometimes there'll be lesions that just don't respond. So I'll have a patient that's getting light therapy 3 days a week. They've been on it for a while, and there's 3 or 4 trouble spots that are just stubborn. They won't go away, or they're growing despite the light therapy. And if that's the case, there's a number of options. You can try to, a mycosis fungoides team of dermatologists and radiation oncologists, we might say, okay, let's add topical nitrogen mustard, or let's try topical steroids, or sometimes they'll say, let's try a course of radiation. Let's give a couple treatments to these trouble spots and keep using the light therapy to manage the rest of the disease. So I would say that if there's a handful of spots that are just not responding, especially if they're symptomatic, they're pruritic, they're itchy, they're painful, especially if they're bleeding, then I think maybe talking to a radiation oncologist to treat those lesions would be one option.
Okay. Let's see. Can tumors in later MF stages be treated with radiation without having tried systemic treatments, or is radiation only tried after the tumors have not responded to other treatments? It's a good question.
That's a very good question. So it kind of depends on the circumstances. I'll tell you, at least at Duke, we generally will take patients who have larger tumors and try to manage that with a short course of radiation to get those under better control, because we know that, like, for example, light therapy is not going to penetrate deep enough. Topical treatments like steroids or nitrogen mustard, they're just not going to penetrate deep enough. And so, and systemic treatments like interferon or targretin are just often not quite as efficacious when patients have larger tumors. So a very common pattern at our institution is to treat these larger tumors with a short course of radiation, and then starting some other regimen for everything else, and then reevaluating at that point.
Okay.
It's not wrong to try other things first.
Mhm.
It's just, if you have a patient that has a really troublesome tumor that's, has a bandage on it because it's bleeding or whatever, sometimes it's best just to get the best treatment for that one and then start with the rest of the things later.
Okay, great. Thank you. I had total body radiation and I developed raised scars in dark areas. Will the darkened areas lighten in time?
Yeah, that's a good question. So there's a couple of different issues here. Mycosis fungoides, because it involves the epidermis, the most superficial layer of the skin, will affect the melanocytes, the cells right at the very bottom of the epidermis that creates the pigment that gives us our skin color. And so it's not uncommon for patients to have mycosis fungoides and after treatment have areas of the skin that's lighter. So hypopigmented, not as dark as it was before, because those melanocytes get negatively affected. They just don't work as well. Contrasting that, radiation therapy will cause some tanning of the melanocytes or make them more active, and so you'll get a tanning effect. In my experience, most patients, the skin will fade very slowly over time back to pretty close to what their pigment was before. I have had some patients, though, after a course of radiation, even a year or two later, say, my skin is just a little darker than it was before. And I can understand how that could happen with radiation therapy. But most people, it will fade, but it can take months to a year or so to get back to where it was before.
Okay. If you have 5 to 6 plaques and have been treating with nbUVB and valchlor for a year, would it make sense to just have spot radiation rather than trying puva for 6 weeks?
If somebody has plaques that are kind of thick, they kind of have some thickness to them, I definitely think radiation is a good way to go, because even puva penetrates deeper than narrowband, but not deep enough for a lot of plaques. So if narrowband is not cutting it and there's some thickness to it, the radiation makes sense. If the plaques are pretty shallow, then it'd be reasonable to try the puva. The puva, you get the added benefit of the psoralen, the medicine that people take before the exposure to the UVA light therapy. So I suspect that puva is a little bit better than UVB in some circumstances. So that wouldn't be a bad strategy. But again, if it's a pretty thick plaque, the external beam radiation may be better.
Okay, thank you. Can radiation therapy on arms and legs cause peripheral neuropathy?
That would be vanishingly rare. And it kind of depends on the dose. So for example, radiation doesn't negatively affect nerves until you get to a dose around 60 to 70 gray. And so it'd be very unlikely for patients to get a peripheral neuropathy from superficial low dose radiation that we use for mycosis. I've never seen that. Now, that said, I've had lots of patients with peripheral neuropathy with mycosis fungoides and other skin lymphomas because of other agents they're on. So the classic example is brentuximab. Brentuximab is often treated for patients with mycosis fungoides, and its primary side effect is neuropathy. Now, a lot of patients with mycosis have been through a lot of different therapies. And sometimes it's hard to tease out what caused what, but radiation very rarely causes neuropathies, especially at the doses that we use for mycoses.
Okay. We have time for just about 2 more questions here. I have MF granulomatous slack skin on many areas under arms and inner thighs. Have you used radiation or TESB successfully on this variant?
I don't think I have any experience in that particular clinical scenario. So I'm going to have to say, I don't know if radiation would be helpful or not.
We stumped you.
I'm stumped. I'm going to have to go home and do some homework.
Oh, goodness. Okay. So what are your thoughts on RT on sensitive areas like the groin and buttocks, including on the inner portions? Is it possible in these difficult areas, and is it safe so near to sensitive organs?
Very good question. So I treat a lot of people who unfortunately have disease in some nether parts of the body that are sometimes it can be very embarrassing to have these areas in the perineum, around the buttocks, the genitalia. And often those areas are very troublesome for patients. They can, be irritating when, rub against the skin. So yes, we treat a lot of people who have disease there. And it's like treating any other area. Of course, if you treat the scrotum, then it's going to affect testicular function. And so it could affect fertility and things like that. Again, depends on the radiation dose. But most people that it's not a big issue for, fertility. The biggest problem is we have to have that area exposed. Like we have to be able to see it and have the radiation aimed in that area. So sometimes patients have to be in some awkward positions for us to treat it. Now, it's not awkward for us as the treating people, but I think it's very awkward for the patients, but we do our best to maintain as much modesty as we can. But radiation can be used. I treat people all the time who have disease in these sensitive areas.
Okay. It's a good question. We get that one a lot.
Yeah.
Let's see. All right, we're on to our last question. How often is radiation therapy applied in marginal zone B cell, and what is the effect?
Yeah. I love treating marginal zone lymphoma. So marginal zone lymphoma is almost, well, let me back up. Most patients with marginal zone lymphoma have a single lesion. And in those patients, we generally treat with what might be termed a definitive course of therapy, which is typically 12 treatments. If, however, the disease is multifocal and it's in a few areas, then often we'll do other treatments like topical steroids, depends on the circumstances. But for example, I had a patient who had 5 or 6 spots. They were all kind of superficial, and they used topical steroids on all of them. And only one lesion was troublesome at that point. Got referred to me. We gave 2 radiation treatments. Marginal zone's great for 2 low doses. Went completely away, hasn't come back 10 years later. But over the last 10 years, I've had to treat him 2 other times. So a total of 3 courses where he gets an area that pops up, we give it 2 doses, it goes away. 5 years later, an area pops up, we give it 2 doses, it goes away. And so we're never going to cure him, but the radiation does a very good job of keeping it in check with just minor inconvenience. So I love treating marginal zone because radiation works really well.
Great. And we actually had that question repeatedly, so glad to answer that. Awesome. Yep. Well, thank you so much, Dr. Kelsey. This has been wonderful and really informative, and we're so appreciative of your time this evening, and thanks for being here with us. And thank you for joining us. Yes, and we hope to see your face again, perhaps at a future program. So you were wonderful. And for the folks tuning in at home, if you wouldn't mind, I did just launch a poll. We take your program feedback very seriously. So please, if you wouldn't mind participating. And thank you so much, everybody. We hope you have a wonderful rest of your week, and happy holidays to everybody. So thank you, Dr. Kelsey. Have a great evening.
See you later.
Bye. I'll leave the poll up here for just a minute to give folks a chance to participate if you wouldn't mind. And we hope to see you at a future program. I hope everybody has a really wonderful rest of your week and evening. I can't believe it's only Monday. Sometimes I have to check my phone to figure out what day it is. I'm sure some of you can relate. So have a great evening, everybody. I'm going to close our poll out here and hope to see you all soon. Thank you so much.